And welcome to Pediatric Grand Rounds, our Zero Harm Grand Rounds, the last Grand Rounds for this season. So is it the last Thursday of May? Yeah. So we'll start again in September. I'm Chris Maloney. I'm the Chief Medical Officer. Katy Welkie, the Chief Executive Officer for Primary Children's in the Primary Children's Region. And we are going to tell a bunch of stories. We're going to tell stories about our journey into Zero Harm through the engagement with HPI, how we're doing, and how we actually can do better. And so some of the stories are going to hit home, and I think that we're going to be done with about 15 minutes left, and we really want to have an engagement and listen to what we're doing right and what can we do better, because there's no way that we can really know how we can do better if we don't have an engaged faculty and staff, and so that's our goal. With that, I'm going to turn it over. I'm going to sit down, and then I'll come back up. We're going to do tag team, and so you'll see us moving around.
Very good. For our safety story today, we want to, that's not working because it must not be on. Shh, there we go. For our safety story today, we want to talk about Maya Ramal. And for a reminder for everyone, in case you don't know who Maya is, she is a beautiful young teenager who came to our hospital in 2011 for a very simple diagnosis of constipation. And through a series of unfortunate errors, she tragically died unnecessarily in our care. And the pain of this death, I think, reverberated through the halls of Primary Children's and created this renewed commitment and energy on creating a culture of zero harm. And we have had an incredible partnership with her family, with her parents, Satish and Sophie Ramal, who I believe will be joining us a little bit late. They're having some family issues this morning. So we just talked to Satish on the phone, and he should be joining us. And when he comes, I would love us to be able to stand up and recognize him for all that they have done. They put past their grief and really partnered with us to prevent something like that ever happening to any other child and for any other family ever again. And they are with us at our side every day that we are doing this, and they're a constant reminder for us of how important this work is. And not only have they been here with us, but they have participated in the spread of zero harm throughout all of Intermountain Healthcare. So we owe a huge debt of gratitude to Sophie and Satish Ramal. I'd also like to welcome two of our board members, our board chair, Rich Kafusi, and Tina Purcell, who is here from our board, and we're so pleased to have you both here today. And as part of today, we get to announce the Maya Ramal recipients for 2016, awarded in 2017. And I first want to recognize the Maya Ramal recipients from past years, or past year. Is Shannon Tripp or Mike Misher here today? Even without them being here, I'd like to recognize both of them for their great work. There was a wonderful film up here about them. And then Doug Wolf, the true father of Zero Harm, our ongoing inspiration. Doug's back there at the back of the room, so thank you, Doug. I'm hoping all of you know that we have several levels of recognition here at Primary Children's. We have this everyday zero harm pin that department heads, physician leaders have abundance of to pass out whenever there is a good catch. And we're hoping that you see those on people's lanyards, on their lapels, and that people are wearing those with pride. If there is an outstanding contribution, department leaders can nominate a physician, nurse, caregiver, anyone in the department to receive a Safety Hero Award for a significant contribution, whether it's a good catch, a culture change, or a process change, teamwork that has really improved the culture of zero harm. And then every year we hold a Maya Ramal luncheon, a zero harm luncheon, where we recognize the most outstanding stories. It's a very tough decision to go through all of the stories, all of the good catches, all of the changes that have been made, and select a few who are deserving of the Maya Ramal Award. And this year we identified two teams for this award, and Fortunately, we have most of them here today. The first is Jake Luke and Michelle Schober from the Pediatric Intensive Care Unit. Jake is a PharmD, and Michelle is one of the physicians in the PICU. And we are going to tell their story in detail a little bit later in the presentation. But for now, I just want to say they demonstrated amazing clinical expertise, the willingness to persevere in not proceeding in the face of uncertainty, and fabulous situation awareness. And so I'd like to have Jake and Michelle stand up and let this group recognize them. The other team are Emily Glenn and Scott Short. At this point in time, Emily was working in surgical services in the PACU. Scott Short is a fellow in cardiac or in general surgery, peds surgery, and will soon be joining the faculty. And they, again, Emily was amazingly persistent in her willingness to speak up for safety, to ARC, to really make sure that she was creating a safe environment and not proceeding in the face of uncertainty. And Dr. Short listened and was able to stop and resolve and prevent a very serious outcome for a patient. And we'll, again, tell that story in detail a little bit later. I think Dr. Short must be in surgery, but Emily is here to be recognized. Emily, please stand and let the group recognize you. You will see their pictures added to the Maya Ramal wall down in the lobby, and we will be able to continue to recognize them throughout the year, and we'll hopefully get videos telling your stories and be able to share them broadly throughout the organization. Neither Chris nor I have any disclosures for this presentation. We do, however, have some objectives. The first is that you will all be able to define the concepts of high reliability organizations and how those concepts apply to reducing harm here at Primary Children's. We want to make sure that you can describe the process and progress that we've made here at Primary in creating a zero harm program, and importantly, understand the role of the physician in reducing harm. And two takeaways. When you leave here today, we want you to understand the patterns that we've identified by reviewing our zero harm events and also our good catches, because we're looking at both of those. And then I want everybody to be able to commit to speaking up for safety, situation awareness, and do not proceed in the face of uncertainty in your daily practice. If every single person can do that, we will have a safer hospital. We are human and we are fallible. And unlike many of your family and friends who work in businesses where that may have little importance, for us, when we fail, we hurt patients. So it is absolutely critical that we take these themes, that we incorporate them in our daily activity, and we think about them every single day.
So you see in the middle here, down at the bottom, it's HPI, and after Maya's death, we contracted with HPI to make us a safer organization here at Primary Children's. And we went on this journey with them. And it's been a long journey, and we're going to continue the journey. It's just that we have now disconnected. It's like the rocket booster. That was HPI, and now we're continuing on, and that's that arrow. So we started in that diagnostic assessment where we looked and learned about what is a serious safety event? How do you classify that? We figured out what are the gaps in our safety culture. We've taken that survey, and we're continue to take that survey. Understood all these analyses. We set expectations. Everybody in this room has sat through 3-4 hour training sessions, right? The leadership methods training, error prevention training. We now onboard everybody that comes into our organization, physicians, staff, all LIPs. They go through these learning sessions, and so it's just now part of the culture. It's part of our training. We build and reinforce accountability through rounding for influence. Safety coaches. We have many safety coaches, and during this presentation, I'm going to ask also many of you to stand up. Katy talked about our recognition programs. We do this on a very regular basis, recognizing when we have great catches. This goes through our daily safety briefing where we share that. We are moving to a fair and just culture. So speaking up for safety is good. We want you to speak up. We don't want people to feel penalized for speaking up, right? If you see something and you speak up, you should be rewarded for speaking up, not penalized penalized for that. And that's the old culture, right? The old deny and defend culture. No, we're a righteous culture. And then the detection and corrections, where we have worked through lessons learned, and we'll show some flyers. In fact, yesterday, many of the staff, although not the medical staff, received the final part of our lessons learned project, and we'll touch on that. Our root cause analysis focused on simplifying our procedures and our policies, and we're continuing to try to build on this sustainable culture. And it is a journey. We're not at zero. We're not at zero. You'll see our run charts to see how we have work to do. And so I really encourage all of us to do that. Speak up for safety. Be situation aware. Do not proceed in the face of uncertainty. Ask for help. And those are really the key themes that we need to move through. Now, I wanted to take a few minutes to talk about a serious safety event. This is a difficult concept for many that you have to work through. And so the definition is a deviation from a generally accepted performance standard. And we follow a very rigid algorithm. And SERP, which is the Safety Event Review Panel, SERP, meets once or twice a month to review these cases. It started out that Doug was in charge of that, as he's in charge of a lot of things that we start out with continuous improvement, and we moved it to now Jeff Sanchez is the lead of that. So we have this algorithm, and the very first question that you have to ask is there a generally accepted performance standard? Is there a generally accepted performance standard in our hospital? Well, if there's not, then let's search further. Is it in our region? Is it in our nation? What about other industries? Should we have a generally accepted performance standard? If the answer is no, that we do not have one, then we couldn't deviate from it, right? And so then we say, okay, then we may need to build a standard. Let's create a standard. And we've done a lot of that over the years. However, if there is a generally accepted performance standard, we ask the question, was there a deviation? If there's not a deviation, then it's not a safety event. So that's that algorithm there. If it's yes, then the next question, did it reach the patient? So we have a lot of general deviations from generally accepted performance standard that reach the pharmacy on a daily basis, right? Doctors are writing orders that are wrong. In fact, we would have to hire more than 1.0 FTE to track all of the errors that the pharmacy picks up on a daily basis. There's that many errors that are picked up by our pharmacists. And so it doesn't reach the patient. We did deviate, and so we call that a near-miss safety event. And then if it reaches the patient, does it cause more than minor harm? And that's where the SERP figures out what is minor harm, what's the definition. And they argue and argue and argue, and they send it back for review, and they bring more data back, and they argue some more. And sometimes it's classified as serious safety event, and sometimes it's not when they have a lot of data. So it's a very rigorous and robust process. And SERP classifies an event as a serious safety event. And that's really all it does, okay? It identifies, is there a deviation from a generally accepted performance standard? And did it reach the patient? And did it cause more than minor harm? And so this table now looks at the difference between what we call central peer review. And we have central peer review in primary children's for the LIPs on the medical side, the Department of Medicine, and on the Department of Surgery as well. And then there are the M&Ms that many of our programs have. They have very separate functions. Again, SERP classifies an event as a serious safety event or not, a near miss, a precursor safety event, or it could be a known complication of that process, where central peer review really looks at ongoing professional performance evaluation. So this is, how does a practitioner do in the daily knowledge, skills, attitudes? So this is now individual performance. So individual performance happens at the central region, so central peer review, or the M&Ms, where we're saying that individual now needs focused professional practice evaluation, FPPE, versus SERP. So I want to make sure that's clear, is that the SERP is just classifying an event. That's what they do. If it's classified as a serious safety event, we move into an RCA, a root cause analysis. We'll talk more about acronyms in a minute. And so Katy's going to take over from here and talk about where we've been, where we're going, and then we'll jump back in.
And Chris talked about that because we've heard there's a lot of confusion. So I'm hoping that that helped a little bit separating those two in people's minds and really providing a little bit of clarity. So where are we today? This is actually not where we are today. This is where we were a year ago, at the end of December. And I actually wanted to point out where we were truly a year ago in the end of May. We were up there right around 1. I'm sure this has got a little laser on it, and I can pretend I can do this. So right here, right about there. So we were about 1 safety event, 1.0 SSER. And what we look at, this is a run chart, and it is a rolling 12-month average of safety events per 100,000 adjusted patient days. And it's just how we measure whether we're getting safer as an organization. When we ended the year last year, we had dropped down below 1 and had a 53% decrease in our serious safety event rate from our baseline. So we started our baseline by looking retrospectively at the events that we had prior to starting our education around serious safety event. So we'd made fabulous progress, and really, really good progress, but we are far, far, far from zero. We're not even down close to where other organizations have arrived at, where they're having 1 safety event a year, 2 safety events a year. So we know that we still have a lot of work to do to get down to 0. And that's why we're here today, to talk about some of the things that we're working on and some of the work that we need to have all of you do to help us get there. Our objective here, the aim, is further reduction of the serious safety event rates, or decreasing harm for the organization. And in order to achieve that, we know that there are 4 behaviors, and we've identified this from looking at the events that we have. There are 4 behaviors. The first is that we need to have increased physician engagement in the techniques and understanding where we need to be. We need better situation awareness. You will see later how important situation awareness is. Knowing where you are, what you are doing, and identifying the risks, the potential risks of what you are about to do. Increased collaboration and teamwork. Where we have that teamwork we get the very best care. And then identifying for our high-risk areas, robust processes and cognitive aids to help plug the holes in the Swiss cheese. We know that most of our events happen in certain areas, and that we have to focus on those in process improvement if we're going to be successful in the long run. So for these sharp end behaviors, if we want to change them, we've put into place several techniques. The first is better physician engagement. The next is to engage the leadership teams in the different departments where there is high risk. We want to, again, focus on those 3 themes. You're going to hear this over and over and over again. So when you leave here, you will remember: speak up for safety, situation awareness, and do not proceed in the face of uncertainty. We need to improve our action plans so that they are more robust, so we're not experiencing that horrible, horrible deja vu experience of, this sounds just like that event we had 2 years ago or last year. And we want to make sure that we can maintain everything that we have done. And that is not a small task. We have a lot of things in place. And so Chris is going to go through in detail each of these 5 behavior shaping initiatives so that we can all participate in them for the future.
Yeah, I'm going to go through them, but Katy's going to help tell stories, because that's part of what we're doing here, right? Storytelling. Physician engagement. So one of the things that we were told that we needed to do was to find a physician face for zero harm. And so we did that, right? The face for zero harm is the face of the CME medical director. So we have Joyce Soprano is our medical director and physician lead for our zero harm physician group. So let's recognize Joyce for all she does. And as many of you know, we sent Joyce into the lion's den. So we had Joyce sign up to come into division meetings for the different divisions inside a primary children's hospital. And by doing that, first she found physician champions. So who is a physician champion? A zero harm physician champion. Stand up. Let's see who you are. We should have one from every division. So we know we have 24 physician champions. Yeah. All right. Thank you. There are many, many more that aren't here. They didn't want to come and listen to us, and that's okay. And One of the goals for Zero Harm and going there and listening to what's going on was also to garner ideas. We wanted to have ideas, safe things that can improve our safety and culture of safety. We wanted 100 of those in the year 2017. We've implemented 32. We've probably implemented more because this slide was made last week. There's more than 60 that are in the pipeline, and so we're going to easily hit our 100. We're going to blow it by. And I'm going to tell you a few of the ones that are the ideas that are already been implemented. So we were hitting high season into February, and our surge plan in the PICU, SICU is to go into the PACU. However, what the physicians noticed that were caring for the patients is that there was a pod on the NTU just around the corner, not down the hallway where the PACU is, that we could we take that room, put patients that we were double bunking into single rooms, move our staff. It'd be a lot closer for the charge nurses and the resource nurses to help. And so John Woods called the MOD, Doug Barnhart, and they said, can we do that? And we agreed that was a safe way to do it, and we moved those patients, and great safety for those patients. One of our interns, at least in the EPAC program, EPAC stands for Education in Pediatrics Across the Continuum. We use a lot of acronyms in medicine. We use a few in Zero Harm education, but we use a lot of them in medicine, so you're all used to acronyms, right? But EPAC student, Chessie Nichols, she said, hey, wouldn't it be nice if the residents had Vocera in the ED? And then we could talk to the nurses if there's a safety event, if we need an emergency. And so that happened, and we did that. Dave Sandveiss formalized a system in the RTU for the physicians to write insulin pump orders for surgical patients, right? What a great idea. What a great idea. Doug Barnhart, another one, create posters for surgical services with Zero Harm themes in the areas where they've been having these serious safety events, right? Put it right in front of you. This is a reminder. Howard Kadish said, look, we don't have a lot of deliveries in our emergency department, but when they come, we need help. So you had put in the OB on-call pager into your phone. So all you do is hit a button and you get help right there. Jill Sweeney added a surge attending during high season in the PICU so we could, again, improve the safety of the patients that we're caring for. Just to talk about a few. Now, I told you that we sent Joyce into the lion's den, and so she came back with a slide for us, and she said, here's the good, here's the bad, and here's the ugly. And you see them, right? So the good, we love the pre- and post-procedure huddles in the OR, right? So the change in culture in there. They do a pre-huddle. What's going to happen? They do a post-huddle. Did it happen? They have checklists, and so those are great things. Error prevention techniques empowers all caregivers at all levels. We love the posters for the messages, and it's very different. This is one person said, they came from another hospital. This culture is very different than a hospital without a safety program. The good, right? What about the bad? Well, the RCA process. I don't understand the process. The meetings are too long. We really need to get caregivers, provider support. Why don't we have that? What about the lessons learned? What are we doing? And you'll see we're working through that, right? Now, we inform you of a preliminary event that may be a serious safety event. We don't give you a lot of details, and sometimes we get feedback of, Maloney, that was ridiculous. Why'd you send that out to me? It's not helpful. And others was, why, thanks for sharing. I didn't know that could happen in our organization. So we're learning. And then this one, it's difficult to learn the acronyms. So let's go through them. We have 6 error prevention techniques. What are they? And if you shout it out and Katie hears you, you get a prize. So let's start with one of them. ARC. What does it stand for? What does ARC stand for? Ask a question. Request a change. Voice a concern. Go up the chain of command. Does everybody know their chain of command? Who is above you directly in your management structure? Make sure you know that, because if you don't know who you go to, who you report to on a day shift, on a night shift, on a weekend shift, on a holiday shift, it doesn't help. You won't get to see. What's another one? STAR. What does that stand for? Review. Excellent, excellent, excellent.
You've got SBAR over here.
Oh, SBAR. What does that one stand for? And when do we use SBAR? All the time. That is true. My emails are full of SBARs. Yeah, but it's when you're trying to have somebody. It's a communication strategy, and it's a formalized communication strategy that you can expect what's going to come. Right? I'm going to give you an S-bar. You know that there's going to be an assessment, and then there's going to be a recommendation. Listen up, or you're going to get arced. Right? Because we moved that into a verb. Okay, S-bar, star, arc. What's another one? Stop and resolve. When do we do that? Before we hit submit or send on that email when you're mad at somebody, right? Brooks, you think?
We forgot Maya's rule with ARC.
Oh, and Maya's rule with ARC. And everybody has their
absolute obligation to speak up for safety.
That's why I gave her the mic. All right, so that's 4. What we got? 2 more. Read back, repeat back.
And we've got standardized handoff right here.
We got another one. Standardized handbook. And what are the 5 P's? There's really 8 of them. Okay, what are they? Patient, problem, plan, purpose of the plan, pitfalls of that plan. All right, you guys are really, really good. So they're not that hard. Remember, you learned, many of the doctors and many of the nurses, on Old Olympus, Towering Tops of French and German, viewed some hops. There's some nasty ones, though, that Katy taught me as we were putting this together that I will not say. I will not say. All right. The ugly. If they really cared about safety, and we heard this last year, then they would pay their nurses more. And we were losing nurses. I can tell you, Katy stepped up to the plate there. Judy stepped up. We are paying our nurses more. So that's great. Messaging. The event review process is unfair. Well, I hope not. I think it's very fair. It's very robust. It's very consistent. And so maybe the review, you feel it because you have an individual performance concern. And that's unfortunate, but we have a process for that. It's called FPPE, and we can work through that. And there's a feeling of, I just work here. And our goal is that you love your job, and so that you never work a day in your life. Yeah? When Joyce put this together and came back, we had these other 3 themes that came out. These were the main safety concerns: pharmacy and medication errors. We needed more pharmacy support in our dialysis, in our transplant, in our neurology. We've done that. We've got actually a medical director for transplant around antibiotics because that's a big deal. Medication reconciliation. Chameleon does not have the most up-to-date medications. Well, guess what? iCentra's coming. October 21st. On October 22nd, we will celebrate the birthday of the conception of Chameleon, and it will also be put to sleep. We will not be using Chameleon effective October 21st, 2017, and the baby that Doug and I created back in 2003 will no longer live to see its 15th birthday, and that's okay. Discharge is a dangerous time, so we need to think about that. Especially, I told you about the great catches by the pharmacy. In our outpatient setting, so we pushed zero harm very big in the inpatient setting, right? Well, for many of you, you don't know that in the outpatient setting, we have primary children's clinics and we have University of Utah clinics. HPI contracted with Primary Children, so we implemented it in those. HPI, we've been working with them contractually and recently just got the contract of what can be shared from Primary Children's to the University of Utah. And now we're going to implement zero harm in the University of Utah clinics. That will be ongoing. It's going to be simultaneous with iCentra, so I don't have any hair because I pulled it all out. That's going to be a big lift. It's going to be a big lift, but we're going to do it. We are going to do it. And then information technology. We spend too much time merging records. Intermountain's not listening to us. We hear we can't do that yet. As an informaticist, I can tell you that you will never hear a programmer or a developer that does code say we can't do that, because we can always do that. It's just, do we have the time, resources, and is that somebody else's priority? And so now, as we roll out iCentra, we're going to be able to prioritize what's important to primary children's development in iCentra. And so you're going to see a lot more, yes, we can, and this is where it fits on the list. Ventilator changes are not documented in the medical record. Well, in iCentra they will be, right? My health messages often disappear. Well, we're going to be moving to a new portal. So as you can see, I have a lot of faith in iCentra, and we're about this close from getting it installed. And that's on a very big calendar. All right. So, energize and support our key areas, right? This is not a top-down process. This is bottom-up. This is engaging teams. This is showing them the problem and saying, we need your help solving it because you know better than I do, sitting somewhere else in an office, looking at email with a lot of S-bars on them, here's how we can solve. Here's the simple solutions. Here's the leverage points in QI parlance. And so we have this in surgical services. So surgical services, after grand rounds last year, they huddled and they said, we want to be the safest OR in the country. I think the next week they said we want to be the safest OR in the world. But I think if they're the safest in the country, that likely puts them up there. That's like the World Series for baseball. We think we're the best in baseball relative to the rest of the world. The SICU and PICU after an RCA, if we're going to intubate a patient on the floor, we are going to huddle before we move that patient to understand what are the possible pitfalls as we move that patient in elevators, out of elevators, around corridors. What can happen? Do we have everything we need? Do we have the people we need? And so those are great things. Our NICU, they had another safety event. Unanticipated extubations, right? And so they're huddling every unanticipated extubation. After the patient is taken care of, they run their checklist. What could we have done better to prevent them? And their unplanned extubations are falling off because they're understanding the areas that they can actually move on. Behavioral health, we had an event, suicide attempt. And what we learned from that suicide attempt is that we weren't really following all of our policies and procedures. We weren't doing visual checks as frequently as our policies say. And we're documenting now, and we're holding each other accountable because we're speaking up for safety. That 200% accountability is what's important. And the big three, right? These are the themes. Now, these do not supplant the error prevention techniques. They fold in, and you'll see that. So what are they again? You can read. Okay, so speak up for safety. I loved this one when we were learning from HBI and Carrie Johnson, and this is 200% accountability, right? I'm accountable for myself, and I'm accountable for the person sitting right next to me. Now, you could say if somebody's on both sides, I'm 300% accountable, but that's not the way he directed it. So I'm accountable for the other person that I'm talking to. We have to do that. We, as Katy said, we're fallible. I bet everybody in this audience has made a mistake. And we may have said that was the first one they made, and that's okay. I've made one, maybe. No, I did. I really did. But we do this. Speak up for safety. So a good story that I had, I got called. I was the MOD. For those of you, the acronym stands for Medical Officer of the Day. And you get called. It's the chain of command right below CMO. So when it's me, I'm both. I can't escalate except to Katy. And so I got called from the OR and said, I'm not putting this patient to sleep for an LP and a central line. And said, what's going on? And said, well, the hematocrit is 5. And I'm going to use some pretty important, potent gases here, and they're not going to have any blood pressure if I use that with a hematocrit of 5. Now, for those of you in the audience who don't know that, the normal hematocrit for a child is probably around 40. So significantly lower. A lot of times we think of a hemoglobin being around 5, so a hematocrit's 15 or 16. So it's exceedingly low. That's unsafe. And so they were aware of that. They spoke up for safety, and they did not proceed in the face of uncertainty. From that, because we had some challenges, this was a specific religion that didn't want a blood transfusion, we created a checklist of the processes and everything that we need to go through to get the Division of Child and Family Services involved, to get a court order, to get a blood transfusion for this patient to be able to save them. I'm going to I'll tell Jake's and Michelle's first. So, patient he was discharged from the ICU around the 17th, 18th of January, went home to Richfield, and then was life flighted back up here 2 days later, and had mental status changes, was lethargic. And Michelle's admitting this patient and says, gosh, that just looks like an ingestion. What's going on? Ran the med list and said, oh, you're on clonidine. That's what it looks like. How much are you taking? This amount. Yeah, that shouldn't do that. It sure looks like an ingestion. It sure looks like clonidine. Hey, Jake, what do you think? And so Jake says, well, it's taking it. And can I see your medicine? Well, it's in it's a compounded med, so it's not a pill, right? And you look at the label and it says exactly what it's supposed to be, and it says, well, that's what it says, and it's compounded, and I can't tell it. He says, look, there's a phone number here. I'm going to go call the pharmacy. So calls the pharmacy and says, how did you make it? And so they go back and they pull out their papers and they say, yeah, this is how much we added to that. This is how much. And Jake says, really? He says, well, yeah, this is how much we added to that. Okay. And he's thinking, he says, now hold on. What if you did that wrong? And so he calls him back and says, is it possible that you added 10 times as much clonidine to this? Oh, maybe I did. And that's what happened. So the patient was discharged, got that medication at home, got lethargic, came back to the hospital because of that, and these guys found it. Yes. So, situation awareness. This doesn't look right. Do not proceed in the face of uncertainty. I don't trust you, and then speaking up for safety. Good job. You got the next one, Katie.
So this is Emily's and Scott's story in the OR. So this patient came back from surgery and had a Broviac line placed and had a bit of a complication. They said that the patient had bled in the OR more than usual. Patient comes back, and Emily, you can correct me if I get this wrong. The patient comes back into the PACU, and a little bit more oozing around the site than is normal. It's an ephemeral site, a little bit more oozing than normal. And the extremity below the line is a little cooler than the other extremity, and she tries to Doppler a pulse. This is an instrument that you can use to both hear the pulse as well as feel the pulse, and she can't Doppler a pulse in that lower extremity. She can in the other leg, but can't in the leg that has the catheter in it. So she calls the nurse practitioner for the surgical team and says, "I'm concerned. This is not right." She's very situationally aware. She knows what it's supposed to be like. She's thinking about the potential risks that come with line placement, and this is uncomfortable, and she doesn't want to proceed in the face of uncertainty. So the nurse practitioner says, you know what, I think we'll just go ahead and transfer that kiddo to the floor, and we'll go by later and we'll take a look. And Emily says, nope. I'm not quite comfortable with that. I really need you to come and see that patient, which is a really fabulous ability to speak up and to be able to express what you need. I mean, that's very much when we go through our SBARs. It's being able to say, this is what I recommend or this is what I need. So the team came to the bedside. They said, it's probably just the Doppler. You know how those Dopplers break all the time. We're really good at explaining these things away. So she got another Doppler. And you could hear the pulse in the other foot. Couldn't hear the pulse in the foot where the catheter was. And so they went and got the ultrasound machine and looked at it. And indeed, there had been damage to the vessel. And Dr. Scott Short listened and was able to use the ultrasound to be able to identify the error. And then he stopped, he resolved, he took this patient back to the OR and probably saved the kiddo's leg. So between Emily and Scott, there's a child walking around who is in a lot better shape than would have been if Emily hadn't spoken up. So Emily, thank you. Scott, thank you. Really fabulous, fabulous work. Oh, Nicole. Sure. One other story. This is just, I think, a really great one, and to demonstrate that everyone has a chance to do this every day. Nicole Ball works in our foundation, and she was riding down the elevator in the Eccles building, and she was there with a mother and a father and a baby in arm and another little kid. And they got to the first floor, and everyone walked off of the elevator, and the family started walking towards the cafeteria, and the little kid started walking out the front door. And Nicole was sort of like, excuse me, to the... And welcome to Satish. We're so glad you were able to make it, Satish. No, we know you were dealing with family, which is the most important thing. So, but Nicole watched this little kiddo walking out the front door and said to the family, "Hey, is this your son?" And they were like, Nope, never seen him before. He just got in the elevator with us on the 3rd floor. So Nicole appropriately stopped and resolved. She went out, she grabbed security, she went out, she got the boy, and she was able to reunite him with his family, who were still up on the 3rd floor of the hospital. But she was aware. I mean, it would be so easy just to walk on by that and not really pay attention to what's going on around you. But she had that situational awareness and was willing to speak up and then resolve that. So great work for Nicole.
All right, well, we did have some serious safety events, and we categorized those into these themes. Was it the predominant theme and the contributing theme? And what you see is that don't proceed in the face of uncertainty happened 4 of the 14 times. Lack of situation awareness happened 8, and not speaking up for safety was 2. However, if you look at contributing factors, 80% of the time, it's proceeding in the face of uncertainty. 100% of the time, it's not being aware of the situation. And half of the time, it's not speaking up for safety. We have a ways to go. We need to get this, we need to remove these. We need to get down to 0 harm in our hospital. Improve corrective action. So we've been working on this, and as Katy alluded, we have these RCA action plans, and we implement them, and they're not really active. We see the same thing happen again. And so we needed to build a more rigorous structure. We initiated this with the surgical services, with cognitive aids, and they're doing a remarkable job. We talked about the huddles. We've improved the rigor on auditing to be sure that we're doing more than just lip service. So CLABSI, and Katy's going to talk about this in a minute, and I think I've told too many stories because we're way over time, is we need to make sure we're auditing the maintenance bundles. And you'll see K cards, which we started last week. We called a War on CLABSI in our CICU, and we are auditing every day. We're auditing lines to make sure that we're doing the right thing for patients. Now, it may be that the maintenance bundle doesn't change our CLABSI rate. So our leading indicator, which is we're doing the maintenance bundle, may not have an effect on CLABSI. If that's the case, we can check that off and move on to something else. And so you'll hear as we go on the rest of the year talking about leading and lagging indicators as well as visual management systems, because you got to see it in order to do something about it. We've built a more robust RCA oversight committee that meets on a monthly basis. We have a rigorous checklist of, if we implement this action plan, would it prevent a future case of happening? We do that for approving action plans, and we do that for closing. And we're going to see how that system works. It's ongoing, and it's because we're listening to you. You're telling us we need to do a better job. And maintain all that we've built. So continue the 0 harm prevention techniques, which are stop and resolve, SBAR, STAR, ARC, Myers rule. Standardized handoff. Repeat back, read back. Yes, so you did it. We have an escalation process, daily safety briefing. This has been fabulous. Every day at 11:15 or on the weekends and holidays at 8:30, we have a group that gets together and they say, here are the issues that we have. We don't have a lot of issues, but we get them resolved. Some get resolved within an hour, some within the day, some within the week. If they're not resolved in a week, they get escalated to administrative council. Administrative council now has ownership of that, and it does get resolved in a short period of time. That's then fed back into DSB to close the loop that you brought this event up, this area that could be unsafe, and we've closed that loop. The quarterly education forums, we've listened to you. They're no longer a didactic session that lasts an hour. We've reduced them 20, 30 minutes. They're interactive. The last one I went to that was supposed to last 20 minutes, people were so engaged they stayed for the whole hour because they're talking about that. We've changed our culture. And like I said, we've onboarded education for everybody. It's part of what we do here. We have a robust event investigation system. So we have an REI, Rapid Event Investigation Team. Within 24 hours, they get together. Is there something that we need to change immediately and roll that out to the whole hospital? And then if it is, we do that. We then move on to an event assessment team, an EAT, where we try to identify, is this a serious safety event? Do we need to get this to CERT fast? Is there something that we need to get out a little bit slower? If it needs to go further, then it goes on to a root cause analysis. We're having daily huddles, and over the next year, you're going to see in continuous improvement that these huddles move out throughout the organization. And Katy, why don't you talk just briefly about the tiered huddles that we're doing?
So we started this about a month ago, and we believe we're probably the first in the country to be doing tiered escalation huddles across an entire healthcare system. So at 10 o'clock every day, all of Intermountain gets on a phone call, so the RVPs and then leaders from the other areas of Intermountain, to escalate issues. And there are really three different reasons that you're escalating issues. You're escalating them because you need help fixing them. You're escalating them because you need to make sure that everybody else is aware of something, and you need to spread that quickly. We had one just this past week where somebody identified a foreign object in an IV bag, and that was able to be spread across Intermountain Healthcare the same day it was discovered, and we were able to pull the lots for all of Intermountain. And then the third reason is to do trending. And right now we're trending a couple of different things. Importantly, imaging equipment that's going down to see if we need to make a change with the contract, and certainly infections, because we're having some issues with infections across Intermountain. So we're trending both of those.
So I mentioned the physician safety coaches. What about staff safety coaches? How many staff safety coaches do we have in here? Stand up. Please stand up. Yeah, let us recognize you. Yeah. Thank you. There are many more. Maybe hundreds, maybe thousands. The recognition program that Katy talked about with the pins, you should strive to get a pin. And then we're communicating the events much more broadly than we ever have, because we're listening to you. And this was one. How do we get stuff out? You're just too slow. By the time an event happens, I never know what's going on. And so we've been piloting this, and we're getting so much feedback, great feedback to change this. Ann Brenneman and her staff are doing a wonderful job. So we hear a potential event. It goes out as a preliminary. Once we get the investigation, information comes back. How can you implement this to prevent something that's similar like it? It's not going to be exact on your unit, in your area. To get ahead of it, you got to get out ahead of it. And then we had our very first final lessons learned that just came out this week. And so we're learning together. We are a learning healthcare organization, and that's good for us. And we have room to go.
And I'm hoping with that lessons learned that everyone who received it will really be looking at how does that apply to me? Because that's how we're going to prevent events happening that are similar in one area to another area. And I've really hats off to the team that's been working on this, Brooks and Ann and the team, because they've really worked to narrow down what is it that you and your department should be looking at and thinking about. So where are we today? We are 7 months into our measurement period. Again, our measurement period for SSEs goes from October through the end of September. And we have 5, maybe 6 events. We're still under investigation on one of them. And so just very quick review for everybody. We had chemotherapy that there was an error. It resulted in immunosuppression and a infection and a hospitalization for that. We had a suicide attempt that resulted in prolonged care at a higher level. We had a failure to observe an umbilical artery catheter while it was being removed. The patient bled, became hypovolemic, and required a transfusion. We had failure to recognize and treat shock that may have contributed to the death of a patient. And we had an infusion through a malpositioned or poorly positioned UAC line that resulted in a liver necrosis. And we are currently investigating an event where an ET tube adapter fell off and the ET tube was not removed while the bag mask ventilation was being done, and the patient's heart rate dropped and required compressions. And so that's being evaluated now, whether that is a SSE or not. So we are doing relatively well, and you can see it here on this grid. You can see where our goal is here for 0.0. I think it's 86 SSEs for the year. We're a little bit above that, but I think we're in shouting distance of being able to actually meet the goal and to have a continued decline in SSEs if we pay attention to our 3 themes and we implement our techniques in an everyday basis. I just wanted to talk a little bit about employee safety. We recognized as an organization that we really can't expect our employees to keep our patients safe if we are not keeping our employees safe. It's not that we haven't been working on this. We've been working on it in a different umbrella, but we brought it under the umbrella of zero harm because it's important to be thinking about it. We look at 2 different measures, the OSHA INR rate, which is illness and injury, and then also the DART rate, which is days away from restricted work or transfer to another area of care. And we've done well in this. You can see a continued improvement. The very last two dots are really the first quarter of 2017. Not quite sure I would use that data, but if you look all the way down to the end of 2016, we've seen good improvement in both of these, both the frequency as well as the severity. And a shout out to our food services department that has done tremendous work. They play around with a lot of sharp objects down in food services and had a very high rate when we looked at the overall incidents within our facility, and they've done a tremendous job of putting in processes and double checks to decrease that over the last year. So congratulations to them. So where are we? National Patient Safety goes, I like green. I'm a really green. I think green's a great color. Don't like the red marks here. We have a couple of red marks in our National Patient Safety goals. Remember, these need to be above 95% when Joint Commission comes. A little bit of work that we need to do in anticoagulation and medication reconciliation. iCentra is going to help this, so got great confidence that's just going to get turned around. Bundle compliance. Bundles are a series of processes or tools that we use in order to reduce harm. And when they're done together, there's evidence that they have reduced overall incidence of hospital-acquired conditions. We have had a decrease in our compliance to bundles for our ventilator-associated pneumonias, our surgical site infections, and our falls. And I would say we've had a decrease overall in the rigor of our bundle compliance auditing, which we have to fix. You can make yourself look really good if you don't audit very much, and we need to make sure we are auditing effectively so that we really know how we are doing in this area. Most concerning is our outcomes here, and that we have increases in two areas. Our CLABSI, our central line associated bloodstreams, and our surgical site infections in our cardiothoracic patients. We're doing really well in other areas, and I do want to celebrate that. Our ventilator associated pneumonias are down, our CAUTIs are down, our surgical site infections in orthopedics and neuroshunts are decreased, as well as our falls and pressure ulcers. So a lot of really impressive progress that we've made from last year to this year. And if you recall, all of them dropped in the previous year and the previous year. So we've had continued really good progress in many, many areas. The CAUTI rate is just a wonderful story, year after year after year, driving this down to lower levels. So far this year, we've had 2 CAUTI infections. I was able to say 1 for many months. We just had another one confirmed just in the last day or 2. But still, that is a fabulous progress that we've made in that area. The place where we have the most concern is in our CLABSI rates, our central line associated bloodstream infections. After many years of progress, we had an uptick in 2016 that set us back more than 2 years of progress in reducing this, and very, very concerning. So far this year, in less than 5 months, we have had 22 CLABSIs, 22 harm events for our patients, 22 patients who've received more antibiotics, longer lengths of stay here in our facility. They're concentrated in our cardiac intensive care unit and our cancer transplant area. And we have had incredible engagement. We have had the teams come together. Judy has declared war on CLABSI, and we've had great engagement from our physicians, from our nursing staff, from their infectious disease, from our infection preventionists, and we are really trying to do everything possible to get these rates turned around. We are starting to audit much more rigorously by using the K cards on a daily basis to see whether or not we have good bundle compliance. If you go to the huddle boards in many units, you'll be able to see this. And I think everyone knows that we are learning our error prevention techniques. We did a baseline last year, and we rechecked it in the fall, had fabulous improvements in all of the areas, even in the physician group, who's now up to over 50%. And I believe it will get even better. Confident we can get that better, but 100% in many areas. So we're continuing to work on that. And what will you continue to see in the future, besides all of the things that Chris talked about? Increased use of huddle boards. Chris talks about the fact that you can't manage something if you can't measure it. And I would add to it, you can't manage it if you don't have it visible to everybody on the team. So we will begin to show everyone the leading measures, so how often you're doing your audits and how that's impacting our central line infections, how often what your engagement looks like, your satisfaction, your operational effects. So you'll see huddle boards everywhere. We're going to continue to work on idea generation. If you are a leader and you believe that you're going to come up with the best ideas for your department, you are wrong. You are really wrong. You need to have your team engaged in solving the problems and listen to your team. And so we're really going to be encouraging our leaders to listen to their team members. I talked about escalation earlier and talked a little bit about everybody needs to be on the same page. So thank you on behalf of Chris, myself. Thank you for everything that all of you have done to decrease our zero harm, our harm events this year, and to move us closer to zero harm. So thank you. And we have a few moments.
Questions, comments?
And we'd really like to hear worries about what's happening. Where are we still not hitting it? What more do you need? What are the concerns that exist in your department, in your mind, around zero harm? Or great things, if you want to share great things too, but really want to hear some of the concerns as well.
I'll give you a pin. I got
oh, there we go. Andy's got a.
Andy has one of my pins, I think.
Here.
Greedy for more. So, I mean, Chris and Katy, I love your enthusiasm about iCentra, that it will fix everything, and it's a counterbalance to my natural cynicism. But there's a lot of data out there that says that implementation of an EMR is a dangerous time. So one of the things I thought we might want to do is, instead of pretending everything's okay, have some way of Joyce or someone collecting issues that affect safety with EMR introduction and circulating them on a daily basis as we discover mistakes that we're making, errors in the program, our poor understanding of it, our poor ability, because of our advanced age in my case, to adapt to it. Because I think we really have to acknowledge that it's a dangerous time.
I think we absolutely agree it's a dangerous time, and I think we'll not only have Joyce, but we'll have Eric, who is, really learned to understand the in-depth nature of the errors and the potential errors of the new system. And we will be using the whole techniques of speak up and solving problems and using all of our zero harm techniques in order to address that. We will be meeting on a daily basis during the go-live period and looking at every single issue that is brought up. I would urge everyone to never hesitate bringing the concerns up, because that's going to be the problem. If people think this is going to get fixed without mentioning it, or if they've mentioned it once and it didn't get fixed and they think, this is useless, please don't get into that mindset. Please continue to bring up any issue so that we can be tracking it and getting it resolved on a quick basis.
Or if you just think that the mistake was your mistake because you weren't smart enough to figure it out.
Absolutely. Or you can
In
the same place, or if you even think there's a potential that this is going to create a problem, we want it brought up. So I absolutely agree. I think the advantage of really having zero harm techniques honed will only help us as we move into the iCentra. I'm not that Pollyanna about it. I know there's going to be problems.
This is just a follow-up on that comment. Is our neighbors next door, one of my family members had a procedure scheduled, and they had already been on a new system, but they upgraded it over the weekend. Monday morning, they could not get all the patients populated. They were 2 hours behind on all the procedures and had no system as to how to do it by hand. Could we have a backup system how to do things by hand so we don't delay procedures?
Yes, we have we have downtime procedures. They probably did too. They just didn't activate them because they think, you always think that, well, this is going to be solved in 5 more minutes. 5 more minutes. Let's not bring out the buckets and start doing manual. We're going to kick it off a lot faster than that. We'll have a command center open, and we're going to be very aggressive at solving problems.
And I also know that the iCentra folks are weaving in our 3 themes, which are speak up for safety, use situation awareness,
and don't proceed in the face of uncertainty. But they're weaving those into the messaging around iCentra rollout and go live.
Yep. Tina has a comment right here in front.
Okay.
Hi, so being a parent who has a kid that comes to this hospital for the past 17 years, of course, the one thing out of this whole presentation that stuck out in my mind is the comment that came from an employee, or maybe a couple employees, that I just work here. I don't want to believe that anybody here said that. I don't want to believe I'm walking into a room with a sick child who is going to be taken care of by somebody that says, I just work here. Because I just bring my child here because I believe this is his best chance. When my child has chronic lung disease, when he gets sick, this is his best chance. And so I hope that we're going to turn around that attitude. And I think with our programs here, I think with what we're doing, we can. And the other thing I want to say and add to all this is please listen to us when we have a concern about our kid. Okay, we're with them 24/7, and we know, or at least we hope, we're giving you the information you need to help take care of our child.
Thank you, Tina.
Thanks. And thank you to all of you. It's only through all of your work that we're able to do this, so thank you.
Have a wonderful summer. We will not be here next Thursday, so if you show up, there won't be any grand rounds. Thank you. Have a great summer.